So welcome everyone. I'm Jessica, so the LTCI operations lead. I'd like to take a moment just to welcome you all to our second long-term care initiative learning series event, a virtual one. We're very excited to have you all here today. Thanks for taking the time to convene with us virtually. I'd like to start with a couple of housekeeping items, so please keep yourself muted. Noise can amplify very quickly in the background with this number of people. There are CME credits available for this event. A member of the LTCI team will email you a certificate within a few days of the event, so look out for that. So we have Dr. Elliot Lass on Choosing Wisely with us this evening. Our agenda tonight allows for a full 25 minutes of Q&A at the end of the presentation. So if you have a burning, pressing question during, then please raise your hand and we can unmute you, or you can use a Q&A box, but also know that we have quite a bit of time at the end of the event as well. So if you could save your big questions for then, it'd be great. At the end of this session, there will be an evaluation. Please take a few moments to give us your feedback. It's of our particular importance now that we are virtual, so we need to learn and grow. So your feedback is very important to us. So without further ado, I'd like to introduce our presenter for the evening, Dr. Elliot Lass. He is a care of the elderly resident at the University of Toronto. He works in long-term care at Baycrest Health Sciences. He's a family physician at Mount Sinai Hospital, where he works in the COVID Assessment Center. He sees elderly patients in their home-based primary care team, as well as practices and supervises trainees in family medicine. One of Dr. Lass's passions is in choosing wisely and resource stewardship. He is currently on the National Family Medicine Advisory Committee for Choosing Wisely Canada. He has been working with the Long-Term Care Medical Directors Association of Canada to adapt their Choosing Wisely Canada long-term care recommendations for the COVID-19 pandemic. So without further ado, please welcome Dr. Lass.
Okay, thank you for that introduction. I'm also now working at the vaccine clinic. So that's another thing I'm doing, which when I sent in my bio, I hadn't done. So that's something interesting about me as well. And I understand there's a nice mix of people. I'm not going to start my slideshow yet. I'll just talk for a second. I heard some family physicians who do long-term care, some nurses, some pharmacists, I think, potentially. Am I missing anyone, just so I have context of what everyone's backgrounds are? If not, then I will get started. So I share my screen. Everyone can see the screen okay? Thumbs up.
Yeah.
Okay, so this talk is choosing wisely in long-term care during COVID. And of course, this is one of my huge passions in life, choosing wisely. I got started with them in medical school about 8 years now ago, and now as a family physician, I've continued on with them, and I did residency projects with them and fellowship projects with them, and now I'm here today speaking nationally about it. Unfortunately, not in Victoria. I would love to be in Victoria, but I'm going to be in Toronto right now, and one day soon, when this pandemic is over, I will come to Victoria to meet you all in person. And I will for sure upload these slides as a PDF to Jessica, and she can distribute them as well. If any of you are on Twitter, I'm not sure if any of you are tweeters. My Twitter handle is elasmd, and we'll get started here. So before I get started, I don't have any financial disclosures, but I do have some potentials for conflict of interest. So number one is I'm on this Choosing Wisely Canada Primary Care Advisory Committee, which is made up of family doctors across the country, but they don't pay me to do that. So it's not really a financial disclosure. I just do it out of the goodness of my heart and because I'm very passionate about it. And then I also, we're going to talk about the Choosing Wisely Canada long-term care recommendations as part of my fellowship, my long-term care fellowship, where I did care of the elderly. I did my academic project on creating a new recommendation that is COVID-19 pandemic specific. So we'll talk about that as well. And I didn't get paid to do that either. I just did that because it was part of my residency And so none of these positions were paid. I also should mention I have a passion for caring for older adults. And I don't think I recognize any of these names, but actually I gave a similar talk to UBC. I changed some of the slides, but if any of you are part of the UBC Dine and Learn event a few months ago, then you may have already seen most of what I'm talking about today. And if so, I apologize, but that was a really cool opportunity. And then that's what gave me this opportunity here to speak to the folks just west in Victoria. No other biases here. So just going to give you a quick overview of Choosing Wisely Canada in general. We'll talk about their long-term care recommendations, including the newest recommendation that I can take partial credit for, as well as talk about Choosing Wisely Canada for COVID, and then talk about some of the COVID adaptations we can make for long-term care on how to be better stewards of healthcare resources. So as you may know, we do a lot of things that are unnecessary in our healthcare system. So CMAI, which is this national body, in 2017 put together a report saying that 30% of what we do, so that's test, treatments, procedures, associated with, they looked at 8 recommendations, particularly in family medicine. They said that those were potentially unnecessary. And so just to go over a few of these, in Alberta, they found that 30% of patients with low back pain were getting imaging without any red flags, and we know that we shouldn't be doing that. In Manitoba, Saskatchewan, and BC, they had quite high rates of low-dose quetiapine or antipsychotics in children and young adults, even though that's not recommended to do by the experts. As well, this is going to be very relevant to long-term care. 1 in 10 seniors in Canada use a benzodiazepine or a sedative hypnotic on a regular basis, even though that is not recommended by experts. Lots of issues, falls and delirium and all sorts of things that we don't want in our older adults, particularly in long-term care as well. And then lastly, in Ontario, Saskatchewan, and Alberta, they found that 18 to 35% of patients who had a low-risk procedure, so that's something like a cataract surgery, had a preoperative test beforehand, like an ECG, which is way too much. We don't need to do ECGs for low-risk procedures like cataracts. I hope based on these examples you've learned here already that more is not always better. And if any of you use this much mustard on your hot dog, please let me know, and I'll make sure to buy more mustard before having you over for a barbecue. I'd love to have you all over for a barbecue one day. If you're ever in Toronto, let me know. So this here is a physician. We're going to try and get some engagement. I'll take a look at the chat. But my question to you is, why do you think physicians in general, or nurse practitioners or clinicians, why do you think they don't choose wisely? What are some of the incentives not to choose wisely? What are some reasons why we don't choose wisely? You can feel free to type in the chat if you have any answers. What kind of pressures are there causing you not to choose wisely? Pressures from families and teams, yeah, that's great. Time, people want a quick fix. Fear of missing something, that's a big one. That's good. I came up with a list as well. We'll compare lists. I think some of them are the same. So I came up with the patient wants it. That's a big one. New tests are good. So sometimes, you learn about an HLE B27 and you say, let's order it because it's a new test and I'd love to order it. Why don't we give it a shot? Better to do something than nothing. Sometimes as clinicians, we feel a pressure to do something. And I'm not sure if you guys have heard of Wendy Levinson. She's the chair of Choosing Wisely Canada and came up with this whole program internationally. she always says, don't just do something, stand there. So sometimes it's better to just not order or not do the test. Or sometimes a referring doctor wants it. So sometimes the neurosurgeon says, I won't see this patient unless they have an MRI. So that's a pressure. I don't want to get sued. Yeah, a few people have mentioned CMPA as a pressure. Bigger deal in the States, but still a big deal here in Canada as well. Sometimes there's financial incentives to not choose wisely. So particularly for things like cardiologists to do more ECGs or more echoes, there's definitely that financial incentive there. And then I've always done it this way. So that's a big one. So that's why we do education. The later you are in life and further away you are from medical school, the harder it is to make changes. And so that's why doing education from the beginning to medical students as well, continuing education is important. And so that's what I can try and fix here today if it's happening. And I'm sure you're all great stewards of healthcare resources already. And so I'm just going to be telling you stuff that you already know, which would be great. So Choosing Wisely Canada is the national voice for reducing unnecessary tests and treatments in healthcare. And what is Choosing Wisely? I'm sure you've all heard of it, but it's important that you guys know that it's clinician-led. It's not some government body saying to do something. It's a bottom-up approach, so very grassroots. It's evidence-based, so we don't do anything just because we want to. We do things because that's what the evidence says. And it's important that everything that we recommend is because it's better for patient outcomes. A lot of skeptics will say, oh, this is just being done because you want to save some money. Yeah, we'll probably save some money at the end of the day, but that's just a positive side effect of doing better care. And then Choosing Wisely is simple. So organizations, they come up with lists, and the lists have recommendations, and they're pretty easy to follow, and they're all guided by evidence. So this is a general list. It's the 4 questions to ask your doctor as a patient. And I think it's also helpful as a clinician or whether you're a nurse, a pharmacist, to remember that these 4 questions are out there. So do I really need this test, treatment, or procedure? What are the downsides to doing the test, treatment, or procedure? Are there alternatives? So are there simpler, safer options? And what happens if I do nothing? And these 4 questions have been shown to empower dialogue amongst patients and physicians or clinicians and help strengthen that communication. So that's Choosing Wisely in general. I'll just take a quick look at the chat to see if there's anything extra. Yeah, the paradigm of care not understood, pressure to X-ray for referral purposes. Exactly. So Choosing Wisely Canada in long-term care. So we have a tough time because we do have complex patients. And CMAI, which is the same organization that came up with that 30% statistic, they've illustrated that long-term care settings are an area of interest and for potential improvement. Our patients are complex. They have more comorbidities. There's more uncertainty with stewardship of their care. And that's because, if you're with for those of you who do, let's say, primary care and long-term care, you know that a patient who's having a UTI, they tell you, doctor, it's burning. But a patient who has dementia, and of which 54% of patients in long-term care have dementia, it's difficult for them to communicate that they have a UTI. Some patients in long-term care, they have spinal injuries and they may not be able to have sensation. A lot of patients have catheters. So it just makes things a lot more difficult. And there's that temptation to overtreat in this setting, especially with things like COVID-19 going on and potential for community spread of viral pneumonias and other things. So I totally see where people are coming, and there's lots of uncertainty out there. And I agree with you, David. We definitely need to try and create this culture of where we can choose wisely better. So These long-term care recommendations come up with with lots of different governing bodies. So the College of Family Physicians of Canada has endorsed them. The Canadian Nurses Association has endorsed them, as well as the Long-Term Care Medical Directors Association of Canada. They actually came up with this list. And actually, when I worked with them to create the additional recommendation, it was I probably spent I think it was like 3 or 4 meetings that I had. It's a pan-Canadian group of medical directors, and we put forth our recommendation after discussing with them some of the potentials for improvement in long-term care, especially during the pandemic. And I want to highlight how important it is to have these nurses on board, because as a physician who works in long-term care, the nurses are really the eyes and ears on the ground, and they're there 24/7, whereas I may only come in once or twice per week. So it's really important to have great nursing support, as well as, of course, pharmacists and other allied health. So I'll get started with the recommendations. There were 6 recommendations. There's now 7, and I'll talk about all of them today, and we'll go through each one a little bit in depth. If you have questions, we can stop to chat. If it's a long question and you think it might be a longer discussion, we can hold that question and we can have a discussion at the end. There'll be lots of time. So number 1 is, don't send the frail resident of a nursing home to the hospital without reviewing goals of care and advanced directives with the resident or the SDM unless their urgent comfort and medical needs cannot be met in their care home. So transfers to hospital may result in increasing morbidity. A Canadian study noted that 47% are considered avoidable. As you all know, when you transfer a patient or a resident to emergency room, they're facing an unfamiliar and stressful environment. I'm pretty healthy, and when I go to the emerge and I hear all the beeping and the code blues, or protected code blues they are now, and all that goes on, it can definitely cause the average person, to be upset, let alone our frail elderly patients who might have some cognitive impairment. And so these hazards in hospital include delirium, hospital-acquired infection, medication side effects, sleep disturbances, and deconditioning. So that's a huge one. We don't want patients unnecessarily hospitalized. And then everyone has seen this in the past. The patient or resident comes back after a long hospitalization and they've never been the same. So we don't want hospital transfers unless it's within their goals of care. And so what we can do is, if the transfer is deemed necessary, so the SDM wants it, or you feel that it's also within their goals of care, it's very important you give clear instructions to the hospital of what the patient's needs are. So whether they have specific care plans or what the specific concern that you have, it can help could go a long way for the emerge doc. And I'm not sure if this is set up in BC, but when long-term care docs in Ontario, when they write a note to the emerge doc explaining the situation and why the transfer is happening, the emerge doc can also then bill a consult code when it gets to the emergency room. So it's a collegial thing to do for your colleague, but more importantly for the patient care. So understand patient's goals prior to the change in health status, and if possible, confirm them before making that transfer. In goals of care, it's not just, are you DNR or are you full code? There's lots of different layers to it, as you all may know. So whether or not they want resuscitation, medical management, hospital transfer, different interventions like surgeries and transfusions and IV fluids versus oral or IV antibiotics, whether or not they just want comfort at the end of the day. And so having that fulsome discussion with the patient or the SDM can go a long way. I really like the Speak Up Ontario. It's a really great resource. It has a COVID-specific advanced care planning for long-term care, and I really recommend you all take a look at it. So it has this great flow diagram where you need to be prepared, understand the illness, inform based on the patient's values and goals, and then make a plan. So number 1 is done. Number 2, so don't use antipsychotics as first choice to treat behavioral and psychological symptoms of dementia, or BPSD, as we call it. Antipsychotics are very commonly prescribed for behavioral symptoms, unfortunately, for residents with dementia. Sometimes they're necessary, sometimes they're not. And if they're necessary, that's totally appropriate. If they're not necessary, then that's an area of improvement. So antipsychotics can cause serious harm, including premature death. These medications should be limited to cases where non-drug measures have been tried and failed. So coming up with a good care plan for if a patient gets agitated is way more helpful than using antipsychotics. That being said, some residents still need it, and it can go a long way. So I'm not here just to say stop everything. I'm here to say let's make informed decisions and do things that are appropriate. Frequently review attempts at reduction or discontinuation to reduce harm. So if you start that risperidone 1 milligram on that patient with BPSD, maybe if things are stable and you can maybe see if 0.75 can cut it, or 0.5, or see maybe their dementia has progressed to a point where they're not having the same BPSD symptoms, and maybe it can be discontinued. So next is UTIs. It's a big one in long-term care. And they're saying here, don't do a urine dip or urine culture unless there are clear signs and symptoms of a urinary tract infection. So don't prescribe antibiotics unless there are lower urinary tract symptoms. So as you all know, that's things like dysuria, hesitancy, urgency, that kind of stuff. But like I said earlier, in patients with dementia, it's sometimes very difficult, and many times very difficult, to tease out whether or not this is a urinary tract infection. And so they did a study, 50% of those tested showing bacteria present in the absence of symptoms. So if they don't have symptoms, then you should not be ordering any urine cultures. Over-testing, over-treatment can lead to things such as diarrhea, C. difficile, resistant organisms, and all sorts of other issues related to antibiotics. It also potentially increases the risk of failure to consider other causes of change in conditions, such as COVID. So you may say, oh, the patient's not acting on their baseline, let's give them an antibiotic. I think they have a UTI. But meanwhile, they have COVID-19, and so you're missing that if you're just going to diagnose and treat everyone with the UTI. So luckily, there's something called a toolkit out there that can help in making these practice changes with regards to UTIs. And so I'm actually today going to highlight that toolkit, which Choosing Wisely has come up with. And if you're not familiar with what a toolkit is, that's okay. A toolkit is, so they're found online. Different organizations make them, so Choosing Wisely has a bunch of them. And they show you the key ingredient of the intervention. They help you measure your performance. So they help with that quality improvement aspect in your career. They help you sustain early success. And they also include some additional resources and patient aids that might be very helpful for you in your practice. So I'll go through the practice change recommendations, and I'll walk you through each of the points here today. So whenever you get a new admission or there's a periodic health examination or new referrals to long-term care, it's very important that you don't just perform a screening urinalysis or urine dipstick or urine culture that's screening for a resident on admission. It's not helpful and can create a diagnostic dilemma if they're considered asymptomatic bacteria. And it's not very helpful, so why do it? A use of urine dipstick or urinalysis, don't perform a urine dipstick or urinalysis solely to diagnose a UTI. It should all be based on symptoms. And what are those symptoms, you may ask? Well, some of you may be familiar with the modified Loeb criteria. Some may not, and that's okay. And for, like I said earlier, some of the modified Loeb criteria may not be as helpful in patients with severe dementia because they may not be able to tell you, or you may not be able to realize whether or not they have increasing frequency. And it's important that when you have a change in health status, you include everything in your differential before you make your decision. What I like about the modified Loeb criteria is it was developed for long-term care, and it also includes distinguishing between non-catheterized and catheterized residents. As you probably know, there are some differences when trying to make a decision around whether or not you believe they have a UTI. It's important that you don't just collect a urine culture based on an SDM request. That being said, the SDMs or the essential caregivers or family members, they know their family member best, better than I will ever know them. And it's very important that you take their concerns to heart and you use that concern to have a conversation, but don't just do that based on their request solely alone. Management of a resident with a clinical criteria for UTI. So they're saying don't order urine culture unless the minimum criteria, like we discussed earlier in step number 3, have been met. And if there's a positive urine culture, same thing here, don't prescribe unless the minimum criteria have been met. Now, once you start prescribing, you want to make sure you're prescribing for the appropriate duration. So for an uncomplicated cystitis, they're saying 3 to 5 days is completely reasonable. And if it's complicated cystitis or acute pyelo, 7 days would be a reasonable duration of treatment. They're saying here to follow up assessment of resident with clinical criteria for a UTI. So patients getting better and they're asymptomatic. We used to say always, always, always finish your antibiotics, the full course. But we've recently learned that that's not necessary most of the time. And that, after a few days, you can reassess the need for the antibiotic. That being said, if they've had bad experiences in the past, of course, you need to use your clinical judgment when making that decision. If you're on the other end, so let's say you're an emergency department nurse or physician, you've just received the patient, don't routinely screen these patients from long-term care with a urine analysis just because they're there. You want to make sure that they've still met these minimum criteria that we talked about in number 3. So they have here some nice supporting materials. So I like this one, Reflect Before You Collect. It's a nice little rhyming one. It's a nice PDF. You can print it off in color, stick it in your nursing station in your long-term care home. And it's just a helpful thing that you can use to educate your staff. So we're now in virtual care, and so I decided to look up, specific to UTIs, what are they saying about virtual care? Because I know a lot of you, like myself, have unfortunately or fortunately been doing a lot more virtual care. And so there's actually a study that was done during COVID looking at a comparison of diagnosis and prescribing practices between virtual visits and office visits for uncomplicated UTI within a primary care network. So just to mention, this isn't long-term care, this is primary care, and this was done in Michigan. So what they did was they used telemedicine visits for assessment of uncomplicated urinary tract infections. They used a retrospective cohort study comparing antibiotic prescribing for UTI between virtual and in-person visits. And primary care network composed of 44 outpatient sites in a single virtual platform. They had 175 people in the virtual group and 175 patients in the office visit group. And what they found was that patients were treated for a UTI through virtual visit were more likely to receive a first-line antibiotic agent versus the second, third, fourth line. They're more likely to receive guideline concordant duration of therapy. They were less likely to have a urine analysis in virtual visits or urine culture, and they were less likely to revisit the urine analysis, urine culture within 7 days. So UTI care through a virtual visit was associated with more appropriate antimicrobial prescribing compared to office visits, as well as decreased utilization of diagnostic and follow-up resources. So one thing that they had in their virtual group was they actually had the clinical practice guidelines readily available to the physicians or nurse practitioners who are making the decisions. And having that clinical guideline readily available helped them make better choices for the UTI that was considered more rational and less unnecessary overall. So the next one is feeding tubes. I'm sure you've all seen in your careers patients, unfortunately, who have advanced dementia, and the SDM says, I'm really worried about my parent. I really think they need to get food in them. Can we put a G tube in them or an NG tube so we can get some nutrition into them? And Choosing Wisely has looked at that concern and said, we hear your concern, but our recommendation here is not to insert a feeding tube in individuals with advanced dementia. Instead, assist the resident to eat. Now, the nurses out here will probably say it's not always practical, which I agree with. But as you probably realize, the feeding tubes have all sorts of issues. So feeding tubes, they do not prolong or improve quality of life in advanced dementia when looking at the evidence and the stats out there. The studies show that tube feeding does not make the patient more comfortable or reduce suffering, and actually does the opposite. It can cause fluid overload, diarrhea, abdominal pain, discomfort, aspiration pneumonia. And I'm sure many of you have been in situations where these tubes have gotten stuck and have caused unnecessary hospitalizations and all sorts of headaches. So they're saying if patients are having feeding issues, try and assist the patient in eating, maybe get an SLP consultation. Do not consider feeding tubes if possible. So long-term medications. So don't continue or add long-term medications unless there's an appropriate indication, a reasonable explanation or expectation of benefit in the individual patient. So these medications all come from the group of, these are all generic or trade names, so they're not the generic, but I'm sure if you look closely, you can see what they are. They are all PPIs. So Choosing Wisely actually has a really great toolkit, which I'm not going to go through, called Say Goodbye to the PPI, and helps you deprescribe PPIs in general, not just in long-term care. And so examples of these medications that can potentially be deprescribed depending on health status and goals of care are things like PPIs, antihypertensives, statins, bisphosphonates, potentially even anti-diabetic medications. You can consider a target of A1C of 8.5%, depending on frailty. So for a healthy person, you're thinking of an A1C cutoff of, let's say, 7. When people are extremely frail, maybe have dementia, you're a lot more liberal with what A1C will allow. And so there's actually an entire chapter in the Canadian Diabetes Association 2018 guideline devoted to geriatrics and talking about that specific topic. Now, I did get a question from the audience earlier today about deprescribing aspirin. I would consider aspirin to be in the same category. All the evidence these days, the past few years, have been showing that aspirin can cause more GI bleeds, and so we don't recommend aspirin. You're not saving more lives. You're causing more issues with the aspirin in general, unless, of course, for primary prevention. Than you are by saving lives. So aspirin is also not recommended. And Dale here says A1C of 8.5 is too low. Yeah, I know some of my colleagues, they'll allow even 10. It comes to a point where the sugars just might be too high, but I agree with you. A1C of 8.5%. You can definitely go a little bit over that in certain populations. It doesn't matter. Agreed. And we'll speak to that actually in the next recommendation. And then David said, speaks to the importance of helping families understand the changing paradigm of care in end of life or late life. Every senior in the long-term care facility is a priority in late life. Agreed, totally. These are discussions that us as clinicians, whether we're physicians, nurses, we can be having with our patients and families for sure. And so keeping these long-term medications can cause issues with mobility, function, quality of life, and mortality. So this segued really nicely into our last recommendation before that additional recommendation that was actually added a month ago. So don't order screening or routine chronic disease testing just because a blood draw is being done. So for example, let's say you're a patient, you're worried about an infection, you might be septic. Okay, let's order a CBC. Let's see what their white count is. Oh, and while we're ordering the CBC, let's just poke them once, and while we're at it, let's add an A1C and a lipids. That's not considered good medicine for sure. You want to make sure you only do things because they're needed, not because you're already there. So don't do these tests unless it adds to quality of life. Screening or routine testing could lead to harmful overtreatment in frail residents nearing end of life and misuse of resources. So an end of life screening is not something that we do unless there's very, very specific circumstances, but I can't think of any off the top of my head. Maybe we can have a discussion about that at the end to see what others do. I'd be really interested to hear what the practices are like here. And there was actually a really great commentary piece, and I think it was the Journal of Geriatrics, American Geriatrics, but Dr. Clarfield, I think he trained in Canada and worked in the States and Israel, a few other places. He wrote a piece saying an ounce of prevention or a pound of trouble when it comes to patients or residents in long-term care and doing screening for them. So it's important that we take, of course, an individualized approach to screening based on frailty, goals of care, comorbidities, life expectancy, and patient preference. So this is the last recommendation. This is the one that we just added a month ago and got just approved by Choosing Wisely, and I helped develop. So don't hesitate to use virtual care to complement in-person visits in order to meet the needs of residents in long-term care during the COVID-19 pandemic. So that here is virtual care. I'm not sure if you guys are set up with iPads in your home or not, or maybe it's all over the phone, or maybe a mixture of both, but they could be really helpful, a really helpful tool that we didn't really have as much of before the pandemic started. So telemedicine nursing homes can reduce unnecessary emergency care. It can contribute to high quality medical care and also decrease hospitalization. Telemedicine should be integrated into primary care of the resident, and there should be reimbursement for telemedicine based on the medical necessity of the care. And of course, more studies are required to understand telemedicine tools and measures and processes for nursing home residents. And I think over the course of the COVID-19 pandemic, there'll be lots of people that are going to be studying this area and seeing what kind of potential there is for future practice change. So virtual care is useful for non-urgent and administrative tasks. In-person assessment should be considered for acute illness or significant change in condition. So it's not a substitute for in-person, but it can be very useful if it's the middle of the night or if it's just a non-urgent thing. And of course, your long-term care home should have standardized processes, including hardware, software, privacy and security, and transfer of health information off-site. Physical presence and virtual care. So physical leadership, on the other hand, can be provided by clinical care and an administrative organization. Physical presence can ease staff, resident, and the public's anxiety. Timely access to care to assess acute change in status, including respiratory complaints and delirium. So there is a need. While virtual care is important, we need to recognize that there is that need sometimes for that physical presence. And there's no better example that I can think of during the COVID-19 pandemic than the outbreak that was in Participation House, which is a long-term care home for adults with disabilities in Markham, Ontario. And for those that don't know where Markham is, it's in a suburb on the northeast end of the Greater Toronto area. And so what happened was in April 2020, they had a huge outbreak. Unfortunately, 6 residents died from COVID, and there were dozens and dozens that tested positive. Now, does anyone know who this person is who provided the physical presence for this leadership here? Anyone want to add to the chat who this is? Anyone recognize this person? Jane, yeah, good. It's Jane Philpott. She was our Minister of Health federally in Canada, and is actually now the Dean of Medicine at Queen's. And interestingly, Markham was her home riding for when she was an MP. And when she heard, and she's also a family physician, and so when she heard that there was this crisis in her home riding, she saw that the staff weren't showing up because they were scared to go to work. It was a very scary time. It was right at the beginning of the pandemic. We didn't know what was going on, and she decided that she wanted to be that leadership role. She handled the media, so it was a big media frenzy. She went on the front lines, and she helped out in any way she could, and made a huge difference in that pandemic, in that outbreak. So that was great leadership that I just want to mention. I'm sure you all have your own stories of when you stepped up to the plate during this pandemic and really made a difference in your residents' lives. And so kudos to all of you for sure. So I'll just, we have 15 minutes here. I'll highlight here the COVID specific recommendations. So Choosing Wisely actually made COVID specific recommendations. So they're saying here, don't go out for non-essential reasons. Keep a safe physical distance from others, 2 meters or 6 feet, and follow guidelines or guidance from your national or local public health authority. So the first, I think 4 or 5 are for the public, and the last 4 or 5 are for the clinicians. Anyone know what this is referencing? If you're reading this, you're too close. It's okay if you guys don't get this pop culture reference. It's a Drake reference. Drake, the rapper, who's a Toronto rapper. It could also be a good bumper sticker for sure. If he created an album. If you're reading this, it's too late or something like that. Recommendation number 2, don't go in person to a hospital, clinic, or healthcare provider for routine visits, preventative visits, routine blood work, or non-essential healthcare without calling ahead. I found this Doctors of BC ad. The time is now. Together we can save lives. #stay home. Tried to find some BC relevant things. Don't go to the emergency department for evaluation of mild COVID-19 symptoms. Use virtual tools or assessment centers if available. And this here is from the British Columbia website support app for a self-assessment tool. I'm sure most of you will remember back, it's funny, a year ago now, don't self-prescribe or request unproven therapies to prevent or treat COVID-19. So here you see some bleach. Don't do that. Don't listen to certain politicians that tell you to do so. We'll skip along. Don't offer non-essential services to patients in person if virtual tools such as telephone or online visits are available. Delay non-essential care and laboratory testing when possible. Don't send frail residents. So they actually stole this one from us. Don't send frail residents of a nursing home to the hospital unless their basic care and medical needs cannot be met on site. And this is the first one for clinicians, or second one for clinicians. Don't give red blood cells based solely on an arbitrary hemoglobin level. Give 1 unit of red blood cells at a time and reassess the need for more. So for those that also do hospitalist work or maybe inpatient work, it's important that we use our blood judiciously, as there have been some shortages as well with the Canadian blood services. And if you are eligible to donate blood, do it. It's a very rewarding thing, and they give cookies and juice at the end. I am 2 away from my 10-time blood donor sticker. So I'm excited for that. I think it's actually a pin. Don't intubate. This is important for us, for those who do emergency practice, but don't intubate frail elderly patients in the absence of a discussion with the substitute decision maker regarding the patient's advanced directives whenever possible. So if you do hospitalist work or ICU work, if you're in a rural setting, then just make sure you have that discussion with the SDM. And then lastly here, don't prescribe unproven therapies for COVID-19 patients other than an approved clinical trial. And this here is hydroxychloroquine, also an issue by certain, certain politicians feeling that it's a proven therapy, but it's definitely not, and not something you should be giving unless it's a part of an approved clinical trial. So I'm just going to briefly talk about the need to adapt long-term care to COVID. So some of you may remember the CMAI article that came out in November of 2020, and they actually compared my province, Ontario, to your province, British Columbia. And before I get started, I would like you all to give yourselves a pat on the back for how much better you guys did than our province. I don't want to understate how devastating the pandemic has been and continues to be, but I do want to mention that you guys have done an amazing job for the most part as compared to Ontario. So I will go through what they found. So many more long-term care residents died, specific to the first wave in Ontario than BC. BC was faster in response to COVID-19 with actions to address public health, long-term care staffing, and IPAC. There was better coordination with public health, greater funding, less shared rooms, which, as we know, shared rooms are a big issue, more nonprofit facilities. There was a study put out by one of the Sinai geriatricians, Dr. Nathan Stahl, who you sometimes would see on CBC or CTV News, showing that the nonprofit facilities did better than the for-profit facilities, which was actually a very controversial study for those that do work in for-profit facilities. And I don't want to understate that there were many for-profit facilities that did very well. And overall, more comprehensive inspections in BC. Links between hospital, long-term care, and public health were stronger in BC prior to the pandemic. Leaders in BC were more decisive, coordinated, and consistent overall communication, and solutions to allow clinicians to effectively choose wisely need to address the root issues. So some of these root issues include things like supporting education. So there to be a process for hiring workers with specific competencies, whether they be nurses, administrative people, physicians that have interests and skills in quality improvement, transition of care, frailty, polypharmacy, cognitive and behavioral disorders. I did a master's basically in quality improvement, specifically in health policy management and evaluation and looking at health systems. You don't need to get a master's, but there are lots of courses out there that can help you in these roles. And by attending today's lecture, hopefully you learned a little bit as well about some of this stuff. It's important that we have good access to PPE or personal protective equipment. So provincial government must manage and ensure long-term care homes, not home shave, but homes have adequate access to personal protective equipment. So that's me working at the COVID-19 Assessment Center at Mount Sinai Hospital in my, looking all happy in my PPE. It's important here that we have good access to vaccination. So that's now a huge thing. And as we've been seeing in this third wave, in general, the long-term care homes have actually been doing quite well during this third wave, despite all the devastations that's going on in the 40 to 50 year old age group, even 60-year-old age group. Those who haven't been vaccinated are having a really tough time, and the ICU rates are going up. But the long-term care homes in Canada have actually been doing quite well. And so we need to increase the vaccine supply, combat vaccine hesitancy, so having a good understanding of the causes and contexts and interventions that are tailored to the individual. So it's very important that you educate your staff, your SDMs, your residents on the importance of vaccination and try and get those numbers up as high as possible. This is me here getting vaccinated and looking all happy. It was one of the best days of my year. And then now I've actually been working in vaccination clinics at Baycrest, the hospital that I work at, the geriatric hospital, as well as with the City of Toronto. And so it's a very important intervention. I've actually also been up in rural Ontario vaccinating some of the remote flying communities. So we need to get as many people vaccinated, as many vaccines in arms as we can. And to help access these vaccinations, we need to create systems for vaccine delivery by prioritizing the elderly and long-term care resident workers. So hopefully you've all had access to the vaccine by now. If not, hopefully you can all advocate to get it soon. Increase family doctor and pharmacists' ability to administer the vaccines in their clinics and storefronts, and also bringing the vaccine to the patient or bringing the patient to the vaccine. So in Ontario, they're actually rolling out a taxi chip program to get those who are elderly who may not be able to otherwise make it to a vaccine center to get them to get vaccinated, and giving them discounts and coupons for to make the vaccine more accessible so they can get to our centers. I'll briefly touch on this cold standard. So this is another toolkit here. They actually adapted it for COVID-19, specific more to primary care, but it's also relevant here as well. I just have to recognize that we have a slightly different population, but majority of acute respiratory tract infection visits can be managed virtually. Do not prescribe antibiotics after virtual visits alone. I do recommend an in-person visit if antibiotics are being considered. These are some nice posters. So I like this one. Sorry, but no amount of antibiotics will get rid of your cold. The best way to treat most colds, coughs, or sore throats is with plenty of fluids and rest. Talk to your healthcare provider. And this is the antibiotic 3 questions, which we kind of already went through with the 4 questions at the very beginning. Just some nice posters to have in your clinic if you also do family medicine or other outpatient work. There's viral prescriptions, which many of you may be familiar with. So viral prescription is a prescription that you can give to your patients in primary care specifically that can allow you to give something that your patients can come home with. So you give them a diagnosis, you check off the box, as well as give them a treatment algorithm. So you check off whether they should take Tylenol or what, and tell them when they should return and why they should seek other medical attention. And it's available in different languages, and there's actually some stamps. I'm not sure if you guys are on PS Telus, but there's some stamps with PS Telus, I believe with Oscar as well, if you use that EMR in your family clinics. And it's available in many different languages. And here it says, myth, patients want antibiotics. But actually, in truth, satisfaction is linked to reassurance, info, and symptom relief. There's also the delayed antibiotic prescription. So that is a tool where you say, I'm going to give you this prescription, don't take it unless you're still having symptoms in X number of days. And so this delayed prescription allows you to fill out when you feel that they should start the antibiotic, and reasons to start it, and reasons to seek medical care. And so there was a study that was done that showed that it decreases the antibiotic use by doing these delayed prescriptions. And it also showed that there's no difference in satisfaction amongst the patients. So this was the study in Cochrane Review showing that there's no significant difference in patient satisfaction when they get a delayed prescription versus immediate prescription. However, the antibiotic use is much higher when they get the immediate prescription, and only a third actually fill the delayed prescription, which is pretty interesting. So it is 8:57. I did amazing with time. So in summary, choosing wisely is difficult in the long-term care setting. I hear you. I'm one of you. I understand it. It's not easy, but it is an opportunity for us to do better. COVID has further then exacerbated our ability to practice high-value care. We've been hit especially hard by the pandemic, our residents and their families, for sure. Standards for quality need to be set and adhered to, and for practicing during pandemics, and toolkits can be employed to facilitate resource stewardship, specifically in long-term care. So this here is does anyone know who makes these? He makes YouTube videos, and he actually just got, I think he works with Apple now as their like chief medical officer, Canadian. Not sure. This is Mike Evans. Yeah, Rod, you got it. So Mike Evans, he's a family doctor from U of T, and he made all these great, I think they're about 10-minute skits with these whiteboards, and he was actually poached, and now he's living in Palo Alto as one of their chief medical advisors or officers for Apple, I believe. And he made actually a Choosing Wisely skit as well. So I'd like to thank you all for having me here. I hope you've all learned that more is not always better. This is me here packing my bags to one day come out to Victoria. I'll make sure not to pack this much if I ever do make it out to see you all in person in the future. And I'd like to thank Jessica for inviting me. I'd like to thank Choosing Wisely Canada for their support, as well as some of my mentors and preceptors who have allowed me to do this work in Choosing Wisely. And I'd like to thank you all for all your questions. I hope to get to most of them over the next little while. Some of them I'm already looking at, I may not be able to answer, but I'll try my best. And thank you so much to all of you. I have some references at the end as well. When I send out the slides, you can take a look. So what I'll do is I'm going to try and scroll up a bit. I'm going to try and get the questions that have come through the chat first. And then I will then open it up to verbal questions. Jessica, do you think they should repeat their question just to clarify, or should I just answer it as I go through?
Whatever you prefer. I think Sunita's collated a couple questions there, so if you want to maybe start there and then go from there.
Awesome. Okay. So Sunita, 8:49 p.m. How long should we use NOAC for atrial fibrillation in the elderly and long-term care? I don't know that question, that answer offhand. I'd have to look up what the guideline says. I'm sorry, I don't have that answer specifically, but I believe there should be guidelines through relevant organizations. I believe Thrombosis Canada has fairly good guidelines for NOACs, as well as some of the Canadian Cardiovascular Society. So that's where I would start in doing my search to see if there's any guidelines that are specific to long-term care. And if there are no guidelines specific to long-term care, maybe there's an opportunity to make one. So I'm not sure that answer. I'd have to consult a thrombosis specialist for that one. Personally, I've kept them on unless there's a huge bleeding risk. Then I'd have to reassess and talk to the family. Brenda Wilson. And does anyone want to mention what they do, or does anyone know the answer to that question that Draga gave about NOAC for atrial fibrillation in the elderly and long-term care, how long we should use them? I'm happy to make this more of a discussion if some of you might know the answers that I don't know the answer to. If not, we can move on. So Brenda Wilson, in long-term care, we have influenza prophylaxis and are required to dose oseltamivir based on renal function. Do you see any reason why we would have to request creatinine yearly just for this? Yeah, I mean, I see your point. That being said, the oseltamivir, I believe, when you use them, I mean, it is evidence-based to give it in certain circumstances, and to have a creatinine ready so you know how to dose it would be very important. So I could see why the creatinine yearly would be used for that. I can see definitely a function for it. But going back to, I believe it was recommendation number 6, just because you're doing your creatinine doesn't mean you need to throw in an A1C and a lipids and all sorts of other things, or TSH, just because you're doing the blood work anyways. That's one of the recommendations that I can definitely speak to. You mentioned ASA for primary prevention, not indicated. Some families struggle with stopping ASA for secondary prevention. So I agree with you. ASA for secondary prevention is something that you should be discussing potentially with your patients or residents. That being said, it's a little bit of a trickier one, and you have to look at their goals of care, and you have to look at their prognosis, and it's a discussion that you have with the family members of the patient. And talk about the pros and cons to doing each. Some people would say, you know what, my mom had a stroke. I'd really prefer her not to have I'd really prefer my dad not to have a stroke, and this is why I'm making that decision. All you can do is you give them the best available tools, and at the end of the day, allow for your patients' families to make decisions that are hopefully rational, and you guide them in the right direction, hopefully. But that's something that you can do as a clinician, whether you're a nurse or a physician or whomever you are. Ella Melick, I hope I said that right, has asked, has Choosing Wisely dealt with TSH targets and tests? I know what you mean, but not teats. I understand that. I believe one of the recommendations, I'd have to just do a quick search, CFPC Choosing Wisely recommendation. I believe it's one of the Choosing Wisely recommendations for family medicine for the CFPC. I'd have to take a quick peek. I'm just, excuse me, I'm looking at my phone so that I can look at the, so in recommendation number 11 of the CFPC, so this is for general family medicine, they say, don't order thyroid function tests in asymptomatic patients. The primary rationale for screening asymptomatic patients is that the resulting treatment results in improved health outcomes when compared with patients who are not screened. There is insufficient evidence available indicating that screening for thyroid diseases will have these results. Whether we're looking at TSH targets, I'm personally, I haven't seen anything on the Choosing Wisely list. There might be something on the endocrinology list. I'm just not as familiar with their list as I am with the family medicine one. But personally, I'm of course a lot more liberal with my TSH in my elderly populations than I am with younger populations. Diane says, with urine testing, have you seen any projects which have reduced inappropriate testing in long-term care facilities? I think it should be continued and less patient palliative. I haven't seen anything specific. I know that there are always quality improvement projects that are going on in different provinces and different universities. And I think I've seen some work in the hospital setting, but I haven't seen any in the long-term care setting, but I wouldn't be surprised if there is research going on out there. Dale says, I suggest a conversation regarding NOAC with the SDM as there is never 100% risk reduction. And when I have spoken to SDMs, they were annoyed by continuing the drugs. Yeah. And like I said, a lot of these things are Choosing Wisely. It's just about starting a conversation. You talk to your patients, family members or the patient, if they're able to, about what you believe the risks and benefits to a certain treatment are. And at the end of the day, it's about starting that conversation. And sometimes patients will say, I want to continue this medication. That's fine, as long as they recognize what the risks and benefits are, and that they incorporate their values and beliefs into that decision. There is so little benefit from Tamiflu, I discourage its use. Roche never released their study. It is a little bit controversial, I agree. I've seen it used a lot, and it is a little bit controversial. I agree with you, Dale. I'd have to look into the study data a little bit more to better understand it. I know it is done a lot in Ontario, and it sounds like it's done a little bit in BC as well. But I'd have to look more into that data to better understand it. I believe there are some, maybe what I'll do is I'll stop sharing. If you guys are comfortable, I can see you guys too. And if you won't have any questions, you can ask them verbally as well, just so we can have more of a discussion, or I can continue reading out the questions or comments. If there is no easily found record of pneumovax administration, should we be giving a dose on admission to an LTC facility? Good question. What do people do? I'm going to open up to the floor. I would consider it. Benefit outweighs risk, and it's covered in Ontario at least. But what does everyone else do? Just maybe we can have a little bit of discussion. Webinar doesn't allow, oh, Jessica's saying webinar doesn't allow for participation video, unfortunately. What about audio? Are people able to do audio?
Yeah, absolutely. They just need to unmute themselves.
Does anyone want to say whether they'd give pneumovax on admission to a long-term care facility? I'd say the benefit outweighs any potential risk.
Can I comment?
Go ahead, Dale.
In BC, the life expectancy on people being admitted to long-term care is between 14 and 20 months. So why would you be giving a person who is essentially a palliative admission injections? It's, you know, when they come into a care home, they're in a brand new environment. And if they're demented and people start attacking them with needles, I don't think it's going to be greeted with any degree of favoritism. And the other, you know, we're obliged to have it on the admission order set. And I've tried to rearrange the order set so people would think about it. And they also have the tetanus shot on the bloody thing, for God's sake. I mean, why would you have to worry about that after being 80 years of age? And, you know, the World Health Organization has basically said that you don't need tetanus vaccinations every 10 years. So anyway, that's all I'll say.
That's a really good point. I guess you need to incorporate the patient's values, beliefs. I have some pretty well patients in long-term care, but I also have, like Dale mentioned, some patients with dementia, and that would cause, you know, agitation and risk, giving them a needle if they don't need it. And so tailoring it to the individual, I think would be a good option. Does anyone else have anything else to add about that pneumovax discussion?
So David Brook here. My problem with immunizing everybody for pneumovax, as we do in many places in BC long-term care facilities, is how old people are dying now. So instead of dying from the old man's friend, they're dying with these horrible ulcers because there's no other way for them to die. I'm watching an efflorescence of burrowing ulcers in my population now, and it is sickening. And these people would have been dead months ago from something that would cause them no pain or suffering.
Yeah, it's a really good philosophical thing that I actually hadn't thought too much about until you guys brought that. And if I ever do meet with those long-term care medical directors, I would bring that up with them as a potential opportunity for advocacy and you know, looking at the guidelines and seeing if there's any other position statements out there around that, because that might be a room for improvement there.
Don't forget
Ron
that.
McFadgen here. I just wanted to weigh in on the appropriateness of pneumovax. I agree with you, Elliot, that despite Dale's contention that the average age is, or the average life expectancy is such and such, we do have a number of patients with more physical and cognitive disabilities and who have longer life expectancies. So I think it's really important to be individualizing that, and having it on an order set should be something that provides an opportunity for the prescriber to consider the appropriateness of the intervention.
Yeah, for sure. Any other questions out there? Feel free to open your mic up and ask your question, or type it into the chat as well. If there's no more questions, I'll give another 10 seconds. From Q&A, we see very few cases of pneumonia causing death. I think pneumovax adds very little to lessening mortality. I'd have to look at the data. Yeah, I agree. If there's no more questions, maybe I'll hand it back to Jessica. And I'd like to thank you all. This has been a great discussion. I've learned a lot as well from you guys. So it's very interesting to see what's going on at the other end of the country. And thank you again, everyone. It's been great.
Thank you as well.
Thank you. Thank you for a very good presentation. Thank you.
Thanks, Elliot.
Yeah, David, I was going to make a, when I mentioned the 4 questions, I was going to make a 4 questions joke with Passover, but I wasn't sure if anyone would get it. So happy Passover to you as well. Jessica, is there anything to add, or are we all to sign out?
No, I think that we're all good. Thank you very much, everyone, for attending.
Okay, thanks everyone.
Thank you for your time.
Bye. Thanks for having me.
Bye-bye.
Thank you so much. That was very informative.